Welcome to Neuroscience CME TV, your personal link to the most widely recognized experts in the dynamic world of the neurosciences. Independently developed by CME Outfitters, the award-winning accredited provider of continuing education in Rockville, Maryland.
Hello, my name is Dr. Charles Nemiroff, Chairman of the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine in Atlanta, Georgia. It is my pleasure to welcome you to the premiere installment of Neuroscience CME TV, the new continuing education series devoted to the needs of the professional neuroscience community. Neuroscience CME TV is brought to you by CME Outfitters, a best-in-class accredited provider of continuing education for multidisciplinary clinical audiences. Every Neuroscience CME TV broadcast is also streamed live and archived at neurosciencecme.com. This site is a content-rich portal that provides disease overviews, clinical trial directories, case vignettes, plenty of CME and CE activities, and much, much more. Many of you are participating in this broadcast via the website, and the rest of you are invited to visit neurosciencecme.com to activate your free account. Today we're going to be covering a large amount of data from the clinical literature and other evidence-based sources. Our goal is to help you translate it into measurable practice improvements for your patients. A critical part of this translational process is the feedback you provide after you return to practice and implement what you've learned. CME Outfitters will be reaching out to selected participants of this activity to learn more about how you translated what you learned into your practice patterns. Your input will significantly strengthen each subsequent educational offering, and for that, thank you in advance. Welcome to Neuroscience CME TV. Today's program is titled Weight Gain with the Atypicals, How to Screen, Monitor, and Intervene. Before we get started, I'd like to ask our internet audience a few polling questions. First, please rate your confidence in screening, monitoring, and intervening for metabolic disturbance. A, extremely confident. B, very confident. C, adequate. Or D, I need more tools for screening, monitoring, and intervening for metabolic disturbance in my patients. Those of you who are watching our program via the internet will now see a window pop up with the question. Please select your answer now and then click on the Submit button. Next, which of the following is not a criterion of metabolic syndrome? A BMI over 30. B, waist circumference over 40 inches in men and over 35 inches in women. C, triglycerides greater than 150 milligrams per deciliter. Or D, fasting blood glucose greater than 100 milligrams per deciliter. Internet viewers will see a new window pop up. Please select your answer now and then click on the Submit button. And finally, how frequently do you currently measure body mass index, BMI, for patients who take atypical antipsychotics? A, every visit. B, quarterly. C, once per year. D, never. Internet viewers, select your answer now. I'll discuss these results in just a minute with our faculty, but first let me introduce today's Neuroscience CME TV broadcast and our learning objectives. Our first learning objective is to recognize the metabolic impact associated with choice of agent, duration of trial, and pharmacokinetic issues, such as metabolites and bioavailability, of antipsychotic agents to minimize risk from weight gain in patients with schizophrenia. Second, to apply recent guidelines to improve clinical skills in screening, monitoring, and intervention in patients with schizophrenia at risk for metabolic disorders. And finally, to employ proper technique for measuring waist circumference and translating the measurement into cardiovascular risk. I'd like to introduce our fabulous faculty who are joining me here today. First, let me introduce my good friend, Dr. Rob Conley. Dr. Conley is Professor of Psychiatry and Pharmacy Science at the University of Maryland School of Medicine in Baltimore, Maryland. He is also the Chief of Inpatient Research at Spring Grove Hospital Center at the Maryland Psychiatric Research Center. Hi, Rob.
Thanks.
Really great having you here with us again.
Thank you very much. It's great to be here.
Also joining me today is Dr. John Newcomer. Dr. Newcomer is Professor of Psychiatry, Psychology, and Medicine at Washington University School of Medicine in St. Louis. He's also the Medical Director for the Center for Clinical Studies. That's a center that oversees all clinical studies in all therapeutic areas at Washington University School of Medicine in St. Louis. And I should, for the sake of clarity, admit that John Newcomer is also a close fly fishing colleague of mine. John, welcome today.
Thanks, Charlie.
Rob and John, thanks so much for joining us on what should be a really exciting program. So let's start today's show by getting your thoughts about our polling results. Rob, I think the data regarding severe mental illness and the link to morbidity and mortality is very powerful and important for clinicians to understand. Can you tell our audience about this issue?
Well, sure. The first thing I think we need to tell our audience about, Charlie, is that serious mental illness can actually be a life-limiting condition. It's very important to know that years can be taken off your life by just simply having a diagnosis of serious mental illness, and that your vulnerability to metabolic and cardiovascular disease is increased. In surveys that have been taken around the country and in looking at data from state mental health systems from around the country, we know that people who have major mental illnesses with axis 1 disturbances, as they're called, will have a decrease in their lifespan, typically from 20 to 30 years. Much of that risk is associated with cardiovascular illness, which is an important thing that people in the past have underestimated. And I think for us, one of the crucial things is that a lot of that risk is modifiable, that if we actually are able to track and treat these illnesses, we can change that problem.
Well, Rob, let me just say that we just got the results that have just been transmitted to me about the first question, and I think you're going to be a little surprised about this, both of you. Mm-hmm. It turns out that 61% of our listeners say they need help and more tools in assessing metabolic risk. Only 6% were confident in being able to do so.
Actually, in some ways, I think that's pretty good news, because I think that all of us really need to learn about this more, and that's a lot of what we're going to focus on today. So I hope at the end of the show, people feel some of those needs have been met.
A lot of the literature talks about relative risk. Could you tell us a little bit about the key difference in relative risk and percentage of death?
Well, I think that with a relative risk of heart disease, you have problems with increasing your likelihood of death. In the past, we've really focused on things other than cardiovascular illness and metabolic illnesses and serious mental illness. We focused on things like suicide, for example, an increase in accidental death. These things do occur with serious mental illness, and in fact, they really cause a lot of the excess death, but importantly, they're not the most serious and number one killers of our patients. And so that, I think, we've tended to underemphasize. And we really do have pretty good data that shows that these problems are not the highest problems in relative risk.
Well, I think it's very important as we discuss this issue to also talk about issues that relate to parity. Mm-hmm. parity of healthcare in terms of patients in psychiatry. And I think the three of us were talking earlier today about the notion that patients with severe mental illness simply don't get the kind of medical care that many of the rest of our society really receives. It may not be the best care possible in the rest of society, but our patients certainly don't do very well.
I think a lot of our patients are really isolated from the typical medical care system. In fact, many of them really have to rely on us in psychiatry as the primary medical care provider. I know a lot of what John has tried to do is really give us data about what we should do if that's the case. But I know from my own practice that almost half of my patients really look to just their psychiatric physicians as their only physicians.
I think more than 30% of patients with severe mental illness have a physician other than a psychiatrist.
Wow, so only 30%
yeah,
overall.
Absolutely.
Yeah, that's troubling but not surprising.
I would agree with you. Let's move and look over here to Dr. Newcomer, and let's see if he can't discuss some issues that relate to severe mental illness in relationship particularly to cardiovascular disease.
Well, John, I'd like to have us focus on one of these slides. We can look at the relative risk of death from different causes. And this is from a study involving multiple U.S. states over multiple years that quantified the age of death in the general population versus the age of death for people with a major mental disorder. That's axis 1 disorders. And if we put up this slide, we can see that, first of all, overall, you were losing something like 25 to 30 years of life compared to the general population. This is data from Ohio that's breaking down the overall causes of death. And both in this Ohio study and in the study that involved multiple states, coronary heart disease was the leading cause of these excess deaths. And here on this slide you can see diseases of the heart, coronary heart disease, but really when we talk about atherosclerosis and cardiovascular disease in general, that also involves the risk of stroke, which is a little further down in this, but if you pool it all together, this is clearly the leading cause in terms of the absolute numbers of deaths in our patient population. Rob was talking earlier about the idea of relative risk, and this is where psychiatry's gotten a little bit sidetracked. Relative risk for suicide is very high because it's such a rare entity in the general population. It ends up being a very big number of the relative risk for suicide in the psychiatric patients. But even though cardiovascular disease is only about twice more common in the psychiatric population than it is in the general population, you're talking about 2 times what's already the biggest cause of death. So this ends up being a very big number indeed.
I think it's very important. We wouldn't think it would be appropriate in a mental status exam to not check for suicide risk.
Of course.
And yet, if we're looking at the highest cause of death rate, we really have not followed up cardiovascular risk.
Exactly.
Well, before we go on to talk about the Framingham study, which of course is focused on cardiovascular disease, I wanted to just mention some of the poll results that we've received, that I've just received and transmitted to me. I think this will surprise you, because the question is, how frequently do you measure body mass index? And let me give you the results, and I'd like your comments from both of you about this. So 12% of our listeners said that they obtain a BMI on every visit. 21% said quarterly, 22% said once per year, and 39% said never. Does that surprise either of you?
Well, it isn't surprising in that we just looked at the fact that patients with major mental disorders are dying of cardiovascular disease. And we've just talked about how psychiatrists are really the primary care provider, at least the front line in terms of screening. I don't think any of us sitting at this table today are trying to turn psychiatrists into internists, but we do think that psychiatrists ought to be participating in the screening and monitoring process.
Well, the fact is we, unlike other mental health professionals, are physicians.
Exactly.
And we have to remember that first and foremost. Just to give you one other comment about the polling before we move on, 36% of our listeners felt that a blood sugar fasting above 100 was not a criterion for metabolic syndrome. And of course it is one of the criteria.
Right.
So clearly this is an important topic that we need to discuss further with psychiatrists. So John, if you could briefly review for us the data from the world-famous Framingham study in terms of cardiovascular risk, I think it would be very helpful.
Yeah, so the bad news is that our patients die of cardiovascular disease more than anything else. The good news is that we know a lot about the prevention of cardiovascular disease. This is arguably the best developed prevention story in medicine today. The slide that we can put up and discuss is from the Framingham Heart Study, as you said, but this is one of a series of large population-based studies that all came to the same conclusion. On the left, you see 5 key modifiable risk factors that emerged from Framingham and these other studies, and these key modifiable risk factors now form the basis of public health efforts around the globe, and certainly for the U.S. Public Health Service. You can see moving from the left, body mass index greater than 27, smoking, elevations in certain adverse lipid fractions. Here we're looking at total cholesterol, elevations in blood glucose, here listed as diabetes mellitus, and elevations in diastolic and systolic blood pressure, hypertension. But on the right-hand side of this slide, you see another key take-home message, and that is more is worse and less is better when it comes to these modifiable risk factors. They're at least additive. And most of these data sets and most cardiac epidemiologists really see some multiplier in there, so that as you start to accumulate additional risk factors, you see some amplified effect on coronary heart disease and cerebrovascular disease risk.
And as you know, because of the lack of parity in the treatment of psychiatric patients, in my experience at least, our patients are much less likely, for example, to be treated with statins to lower one of the risk factors, namely elevated plasma lipids.
Yeah, no, absolutely, and we'll go on and see some great data about that. Perhaps we can start with this next slide, which really shows that the key theme for this talk today, and that is that the prevalence of these risk factors is clearly elevated in our patient populations compared to the general population. You're talking about 1.5 to 2 times the relative risk that you'll see obesity or smoking, diabetes mellitus, hypertension, and dyslipidemia. And I hope we can talk more about this. We're focused on schizophrenia today, but it's not just limited to schizophrenia. You see this in the affective disorders as well.
Well, as you know, there's a whole body of research we won't be able to review today looking at the pathophysiology of why patients with mood disorders are at increased risk for cardiovascular disease, myocardial infarction, more at risk for congestive heart failure, do poorly after a coronary artery bypass graft relative to other patients, more at risk for stroke, perhaps more at risk for cancer. This is really part and parcel of severe mental illness. In fact, to highlight what Rob said earlier, we're talking about years off of patients' lives because essentially patients with severe mental illnesses are an at-risk population.
Absolutely.
And they ought to be considered as such.
That's right. This is an official, potential federal designation, and I know there are plenty of people working to make sure that this gets properly identified in all states in the country.
Well, let's go on to the next graphic, which is, of course, speaks to the issue of identification of the metabolic syndrome. As you can see here, John, we have summarized this for our listeners, and if you could go ahead and review this, we would appreciate it.
Sure. So the National Cholesterol Education Program, the Adult Treatment Panel, ATP, now 3 guidelines, really focus on LDL cholesterol, but then they saw there was added value in bringing in another piece for risk identification, and that is a collection of what we call cardiometabolic risk factors that all center around insulin resistance or reduced sensitivity to insulin action. These are the key components, and in this ATP3 definition, you see specific cutoff values given, and we could debate the individual cutoffs, but this is very helpful in identifying a very much at-risk population. So abdominal obesity defined as waist circumference above certain threshold values, fasting triglyceride above 150 milligrams per deciliter, and HDL or good cholesterol that's too low, that's less than 40 milligrams per deciliter in men and less than 50 in women. Blood pressure being too high, hypertension defined as diastolic and systolic blood pressure greater than or equal to 130 over 85. And finally, a fasting blood glucose greater than or equal to 100. And this number used to be 110, but now it's moved down to 100, so it's in line with the American Diabetes Association's threshold where you go from normoglycemia to what we call pre-diabetes.
And it's important for us to emphasize the fact that this decision to change the definition from 110 to 100 was not done willy-nilly. This is evidence-based medicine. The American Diabetes Association is a group comprised of both diabetologists and patients who are advocates for patients with diabetes.
Well, the important message in here is that it used to be up at 110 because at 110 you start to see this increase in what we call microvascular disease risk, retinopathy and nephropathy, for example. But it turned out we were missing a lot of macrovascular risk, and that's the atherosclerosis contributing to the cardiovascular risk that we're talking about today.
So I'd like to go on, because time is sort of limited, and ask Rob to begin a discussion talking about that balance of tolerability and safety so that we can begin to minimize the risk associated with weight gain. Rob?
Well, thanks, Charlie. Tolerability and safety are both important to people. It's important for us to understand that many times people don't stay on their psychiatric treatment because it is intolerable to them. They have a number of side effects associated with it. It's also crucial that we give safe treatments. Now, the important thing is that a number of the treatments we use are implicated in modifying risk. It doesn't matter what medicines you're on. But also, people need to be treated for their psychiatric conditions. You don't have the option, really, of not treating schizophrenia or bipolar without limiting life in another way. So, knowing that many of our agents can affect these conditions, can change tolerability, can change safety is important. And you'll see that there's modifiable risk factors. Tolerable problems are often considered the so-called nuisance problems. What I'd like to say with that is that when you ask people to be on medicines on a daily basis, nuisance can be limiting on treatment. Safety, on the other hand, we think more as life-limiting or life-threatening things. But I would say most importantly, for most of the things we're talking about today, the issues of metabolic problems, of weight gain, these overlap both. They both affect tolerability as well as safety, and so they're crucially important to focus on. We can modify these risk factors by how we treat people. We can modify overweight and obesity. And it's very possible to change people's weight with drug choice and with other interventions. We're going to see that. We can modify their insulin resistance levels. This is very likely and important to be known to be true. We've found, for example, that no matter what age you are and no matter what weight you are, losing even a bit of weight is very helpful for modifying insulin resistance. Changes your likelihood of developing diabetes and change hyperglycemia and dyslipidemias, and those on a day-to-day basis have a high effect on your overall cardiovascular risk.
So one of the issues that's come up in our field is whether patients develop tolerance to the weight gain. I've heard lots of clinicians debate this issue. Personally, I've had a number of patients who actually have continued to gain weight month after month without showing any asymptote whatsoever.
Right.
Other patients, of course, don't gain weight at all, and then there's everybody in between. And as we talked about earlier, there's no way that we can currently predict before treatment who's going to gain weight and who isn't going to gain weight. But I wondered if you could speak to this issue about year-long treatment. I know you have some data you're going to show us.
Sure. Well, really data that you had originally compiled from a number of sources and a number of studies with the antipsychotics that we use. There is a variability from one drug to the other, both in how much weight is gained, how many people gain weight, and potentially whether or not people continue to gain weight. Although I say that part potentially because I'm wondering sometimes if that's more individual variance. That some people will gain all the weight they're going to gain relatively quickly and then stop. Others have weight that keeps going up year to year to year. I think if you look at the data, it can be, in essence, somewhat misleading because you'll see in the data you put up from one drug to the other that the most implicated drug in the analysis, olanzapine, looks as if people continue to gain weight over time and the 1 year doesn't matter, the curve's still going up. The other drugs are a little more flat, but importantly this data, except for the drug quetiapine, which is all about observed cases, meaning really people who are followed for a full year, most of this data was from last observation carried forward data, which is where people who dropped out early still would contribute to the overall curve, and really you might underestimate how much weight gain is occurring and quite frankly how persistent it is. It's also important to know that this isn't just something that's an issue with second generation drugs. First generation antipsychotics cause weight gain. Chlorpromazine causes a fair amount. They vary. Haloperidol causes less. Tricyclic antidepressants, mood-stabilizing agents. There's a lot of other drugs that are implicated in weight gain, and our patients are commonly on more than one.
So one of the points that I always make when I talk to clinicians is that means are probably not the best way to express data in a way that would be most helpful for them in clinical practice. And the reason is because what you want to know as a clinician is what's the range of weight gain.
Right.
The 20% of the patients gain 50 pounds, for example, and 20% lose 10 pounds. And therefore you won't see that in the mean data, and that's why I always like to see the data expressed as deciles of weight gain.
I think that's a much better way to present it, and also importantly in the sense of conveying risk to people. A lot of times we under-convey risk, and I think it's really important when you even have the concept out there of, well, you're going to gain a certain amount of weight and then it's going to max out. And I think what data we show is if you gain 10 or 20 pounds, that's not a good thing. And it's better to gain 10 or 20 than it is 30 or 40. But that 10 or 20 conveyed risk to you.
Really anything above a 5% increase in body weight, starts to become clinically significant. And we really don't have pharmacotherapies or behavioral therapies that routinely deliver anything more than about a 5% loss in body weight over a year.
Right.
So when you go above 5% gain, you're now out into territory where we don't have easy solutions.
And just to remind the audience that Rob's point about the quetiapine being really a different set of data because it's observed cases, not LOCF, is important to keep in mind.
Yep.
So, John, I'd like to turn to you because all this discussion about weight gain, it worries me a little bit because I'm worried that practitioners out there are thinking, well, if the patients don't gain weight, then we don't have a problem.
Right.
And I know you want to talk to us a little bit about the relationship between obesity, insulin resistance, and address that question I just raised.
Yeah, so the key thing that I think we're worried about is the loss of insulin sensitivity, or the picking up what you call insulin resistance. And about 30 to 50% of the variance in insulin resistance comes from increases in body fat, increases in adiposity. But having said that, about 20 to 30% is coming from fitness. So you might not change fatness at all, and you change fitness, and this could give you some insulin resistance. And then the remaining percentage is genes and from genetic risk. So I think that we see the focus in the public health service on adiposity because it's such a readily measured key modifiable risk factor. But it's good to underscore that this isn't the only way to get there. We worry about this, of course, because sometimes our patients, when they get sedated, lose some fitness, even if they don't gain a lot of weight. This slide is an important cartoon to walk us through how increasing adiposity can lead to insulin resistance. Starting on the left, as fat mass goes up, you increase the release or flux of free fatty acids. This is the breakdown of stored fat. These adipocytes are also releasing hormones and inflammatory markers, but it's this increase in free fatty acid release, especially at night, that appears to decrease insulin sensitivity at key target tissues. At skeletal muscle and liver, it's regulating glucose metabolism, and at adipocytes, it's regulating lipid metabolism. Important take-home message here is that insulin resistance can lead to some key disturbances in lipid metabolism and a characteristic dyslipidemia.
So we're going to now shift our attention to the CATIE trial. Now, I don't think that there is a psychiatrist left in America that hasn't heard about the CATIE trial. It's really been widely publicized. I had the privilege of being on the NIMH Council when we authorized the funding for this effectiveness trial, real-world study to determine the effectiveness and the side effect liability of antipsychotic drugs, typical and atypical.
Yep.
So, John, can you summarize for us the CATIE trial in relationship to the topic we're talking about today?
CATIE delivered really rich data, starting with the baseline data. What did patients at these 52 diverse sites, 1,500 patients almost, what did they look like as they entered the study? Now, of course, with some years of antipsychotic treatment behind them. This next slide that we can show looks at CATIE baseline assessments where you have the subjects with confirmed fasting values in comparison to subjects in the general population. That's the NHANES column. And the top-line result here, men and women with schizophrenia entering CATIE had about twice the general population prevalence of the metabolic syndrome. But what I found even more interesting is you look through the rest of this table, virtually all the individual criteria for metabolic syndrome are also occurring at a higher prevalence in men and women with schizophrenia compared to men and women in the general population. Indeed, the only exception was the men with schizophrenia didn't have a higher risk of the hyperglycemia criteria being met. And that's because of an important secondary message here. Glucose changes relatively late. One of the first things that changes is fat and lipids and blood pressure. And if you want to wait to pick up risk late, then just measure glucose.
So in addition to this surprising finding, on the next graphic, you're going to summarize a finding that I think really struck all of us quite hard, and that was the finding about the rate of patients with metabolic disorders that really were untreated who came into the CATIE trial.
So not only did CATIE at baseline show us that there was a high level of risk, it also showed this very high level of under-treatment. So 88% of the people with schizophrenia entering CATIE with a criterion-level dyslipidemia were receiving no lipid-lowering therapy. 62% of the people who with hypertension were getting no antihypertensives. This is really an important underscoring not only of the risk that we see in the population, but also the level of undertreatment, and it really sets the stage for understanding why everyone now needs to perhaps be on extra special vigilance about this.
So Rob, I don't think any of us were surprised that the patients treated with olanzapine showed the most weight gain in the CATIE trial. Tell us a little bit about how that data in CATIE related to the metabolic changes that were observed.
Well, thanks, Charlie. One of the things that John just said that was very important is that looking at just weight, and particularly looking at the development of diabetes, is really looking at things sort of late. In CATIE, of course, people were randomized to 1 of 5 treatments. Not everyone switched their medication. Many people were already on the same antipsychotic they were randomized to. But in looking at data that really corrected for exposure to drug, you did see that not only was there a weight change, but importantly looking at triglycerides and cholesterol, that people went up on olanzapine, again not surprisingly, somewhat up with quetiapine. The perfenazine cell, the risperidone cell were more or less neutral, and a bit of loss with ziprasidone. So there was a difference. A lot of things we need to do to help people, but one difference can be what antipsychotic they're assigned to, and particularly if you have a person who's in this sort of high risk or gaining category, antipsychotic drug assignment, I think CATIE does show us, does matter.
Just to add,
isn't it also true that Susan Essick at Columbia University did a reanalysis of the CATIE data, looking at the drugs patients were on when they entered the study, and the primary endpoint, which is, of course, time to discontinuation, once that confound was taken into account, isn't it true there was no difference in effectiveness, and that olanzapine no longer had an edge over the other antipsychotics?
Well, that's really important, Charlie. I mean, and that's when I did mention not everybody switched. And we do know that staying on your medications, regardless of what it is, if you look at more time on medicine, in this case the past does predict the future. The longer you're on it, the longer you're likely to stay on it. That makes a lot of sense. You've gotten through tolerability issues, and you will persist more. So when you correct for that, you're right. Susan Essex and her colleagues published just in the American Journal that that switching now was probably the thing that was causing the problem, in a sense. That it was the switch that was implicated with the time to discontinuation, not so much the drug assignment.
Now, John Newcomer has been somewhat of our mentor, all of our mentors.
Indeed.
In a sense, he has taught all of us about the metabolic syndrome and the relationship of various lipids to risk for cardiovascular disease. And one of the points that he's hammered home quite a bit is the relationship between triglycerides and insulin resistance. And I thought it important that he share that with our viewers.
Well, Rob just showed us that data from CATIE looking at the triglyceride change. And if you look at clinical trial data that has metabolic indices, lipids in it, you'll always see this triglyceride signal. And it's very important to understand, there's this long understood observation in endocrinology, that fasting triglyceride tracks very well with insulin resistance. On this slide, you see one of many studies in this area. On the horizontal, increasing insulin response to an oral glucose challenge. As you have more insulin resistance, you have to put out more insulin to overcome that. So as the insulin resistance is going up, notice that the fasting triglyceride goes up in a very tight correlation. Triglyceride is just 3 free fatty acids hooked to a glycerol molecule, so it tracks very nicely with the free fatty acid release from the adipocytes. It's a very important, clinically useful indicator of insulin resistance.
Now, one of the issues that we hear about every day is issues of cost. And we're hammered about the issues related to cost of inpatient care, cost of partial hospitalization, cost of long-term treatment, cost of pharmaceutical. And I think we clearly have to take into account cost of medical treatment for our patients who are at risk for these medical disorders. So I wondered if Rob could share some of that with the audience.
Well, sure, we do have some data about this, and the cost, not surprisingly, does vary. If you are on treatments that are implicated with developing diabetes and go on to develop that, the cost of care goes up quite a bit. Here you see data that parcels out cost of care on various drugs from their diabetes risk and how much of that's contributed by their diabetes risk. I think one thing we've done, we've talked about our patients not having good access to care. A lot of our cost models also tend to parcel out the medical treatment as if, in essence, that also doesn't matter in the cost. But if you look for outcomes as well as cost, you have to combine all those things together. And the true cost of care has to include, for these drugs, things like treating the diabetes that might get caused.
I'll tell you, when I first saw that CATIE data that showed 88% of the patients entering CATIE with a criterion level dyslipidemia weren't getting lipid-lowering therapy, I chaired the Missouri Medicaid Drug Use Review Board, and I instantly thought, oh my gosh, and if we suddenly start to treat all that dyslipidemia right away, we're going to break the bank.
Right.
Well, that isn't the only thing you chair, John. You also chair the APA task force on atypical antipsychotics. I know you've been working very hard on that report. One of the issues in that report will surely be monitoring.
Sure.
And Rob is going to be discussing now and summarizing the current state of monitoring patients on antipsychotic medicines. Rob?
Well, sure. The important thing to know, and what we'll see, is that the consensus is that people should be monitored. And really, it's very much important that psychiatrists and psychiatric care providers see themselves as the primary initial monitors for these conditions. There's a number of guidelines that are available. We'll see this. There's APA practice guidelines, other consensus guidelines. In some ways, I think that it may be, if you're monitoring, the specific guideline you choose isn't so important as much as it is that you're doing something. I think that's the first step we need to get to. With the ADA and APA consensus, which is being developed, we first see that all of the antipsychotics that are being used are thought to be in some ways not just neutral, but implicated at least somewhat. And importantly, I think that regardless of what you're treating a person with, monitoring is crucial. So using the guidelines is critical, understanding from our consensus statements that most things are at least likely, and in most patients it's very likely they'll be on something that can cause dyslipidemia or other problems that lead to these disorders. So then the question really comes into what should you do? How frequently should you monitor?
So one of the big issues here, of course, is that very few of our patients are on monotherapy.
Right.
And they're taking medications like mood stabilizers and antidepressants that may contribute to weight gain, and that should also be taken into consideration.
Absolutely. People really have to be looked at holistically, and importantly, many other medications, over-the-counter medications that are antihistaminic, can contribute to weight gain and also to dyslipidemias. And our patients are vulnerable. We're giving them some medications that likely increase their vulnerability, which sets them up for these sort of synergistic drug reactions.
I think it's very important to emphasize this antihistaminic effect. There's very good data, more confirmation just recently that it's antagonism at the histamine type 1 receptor site that accounts for a lot of the variance in weight gain liability. So the more antihistaminic the drug or the cocktail that people are taking, the more weight gain that you might see.
Well, gentlemen, we're really running a little bit behind schedule, so I'm going to have to pick up the pace a little. Let me ask John for you to go over the next two graphics, which have to do with, of course, the ADA and the APA guidelines for monitoring?
Well, on the first slide, I think we just showed the conclusion that the ADA and the various other co-sponsors came to in terms of differential risk of weight gain, diabetes, and dyslipidemia associated with the second-generation drugs. I would just underscore what Rob said earlier. We could do the same kind of differential risk for weight gain for the first-generation drugs or other pharmacotherapies in general. The more important graphic I want to go for is this monitoring schedule that we could put up. And I think why we've seen a lot of consensus across different consensus guidelines, if you will, is because all of them are really based on what are the general population guidelines, what are the ATP3 guidelines. I think what we're moving towards is why should psychiatric patients get a lesser standard of care than anybody else? This particular ADA guideline for antipsychotic therapy said, not surprisingly, you should know personal and family history at baseline, get some measure of adiposity, blood glucose, lipids, and blood pressure at baseline, measure the weight at every visit, and then repeat at least at 3 months the blood pressure, glucose, and lipids so that you can track these and track response to treatment. We know that both therapeutic interventions and drugs that might have adverse effects can exact important changes within a 3-month interval. So 3-month intervals become an important repeat time for assessment. I think the only mistake on that ADA effort, I say this having spoken to many of my colleagues who were also involved in it, is we initially had set a 5-year follow-up on the fasting lipid profile, and this is really waiting too long. To make an excuse, this was coming from the ATP3 guideline for low-risk individuals. But now that we see so much evidence that our patients are not low risk, at least an annual follow-up is indicated on the lipids.
So, John, let's quickly move now to these very recent recommendations from the National Association of State Mental Health Programs.
So NASPID, the National Association of State Mental Health Program Directors, held a consensus conference really trying to look at all this mortality data that we started with today. And of course it's terribly shocking, and now the whole idea is what can we do to lower risk? The principles that will probably turn into policy for departments of mental health around the country over the next couple of years are going to be, of course, psychiatrists have to be participating in the screening. We have to prioritize high-risk medical conditions. We want to intervene when we see levels of risk, and we certainly need to understand that some of our treatments can contribute to risk, and there has to be monitoring hand in glove with those treatments. And then finally, the key message was there are existing practice guidelines. Let's use them. They're evidence-based. They're going to be a good tool, a good handle to help us lower the mortality risk in this population.
And I think we would be remiss if we didn't say that there were medico-legal issues here that every practitioner needs to think about. Because if you're not monitoring your patients and they end up with a very untoward event, you are in fact somewhat liable. And all of us have been in situations in which we try to help our colleagues in this regard.
That's right. Well, it's practicing defensively, but of course this is good for patient outcomes.
Absolutely. So, John, most often, at least in my setting, when patients begin to show evidence of the metabolic syndrome, the most common strategy is to switch to another antipsychotic. Can you discuss that and show some data relative to this?
Sure. I mean, the options out there are either you see metabolic risk and you do nothing, or some people are trying to treat it with statins or anti-diabetes drugs, but we have very little data on the efficacy of that, and we know that that comes with extra costs. And it's a recent paper in Psychiatric Services that our patients don't adhere very well to those anti-diabetes, antihypertensive drugs. Many psychiatrists are switching. They're going off of what they think might be the implicated or high-risk agent onto a lower-risk agent. These are two short-term switch studies, Pfizer data on the left, Bristol-Myers Squibb data on the right, switching to ziprasidone on the left and switching to aripiprazole on the right. It's a very lovely proof of concept. If you're coming off of olanzapine, switching on to either of those lower-risk weight gain agents, you can actually lose weight over a short-term interval like 6 to 8 weeks. But if you're switching off of high-potency conventional like haloperidol onto either of those agents, not much is going to happen. It depends on what you were taking before.
Okay, guys, we're going to really have to crank it up if we're going to take questions. So, Rob, our poll earlier demonstrated that clinicians need to improve their performance in understanding how to measure weight circumference And so I'd like you to go over some data related to that, and then we're going to move to John, who's going to remind everybody how to calculate the body mass index.
Thanks. Our audience quickly was right on the mark in that they felt they needed more knowledge. If you look at the Shape of the Nation survey, the worldwide poll of primary care providers, it is recognized by primary care providers that this is a problem, that metabolic disorders are a problem. But primary care providers worldwide, over half the time, feel that they're really not monitoring patients in the ideal way. And so I think what John's going to tell us about what to do. The body mass index is real important.
Yeah, body mass index is a key indicator. It's an indirect measure of adiposity, but it's got the most evidence behind it, large population-based studies. Basically, BMI is your weight in kilograms divided by your height in meters, and you square the height. You can also put it in pounds and inches and use this conversion factor that we put up on the slide. But the key thing is that for most ethnicities, a BMI between 18.5 and 24.9 is considered normal weight. Your overweight for most ethnicities between 25 and 29.9, and then with a body mass index equal to or greater than 30, that's considered obese for most ethnicities. Some ethnicities, for example, Asian Americans, you're considered overweight beginning at 23 and obese beginning at 25, and it has to do with genetic increases in risk.
That's important, and we need to know more about that. What about the relationship between BMI and risk for type 2 diabetes, John?
Well, as I said, BMI has been used more than anything else in these large population-based studies. So we could look, for example, at the Nurses' Health Study. Here, as body mass index goes up, the relative risk of diabetes, as you see, once we're up into the obese territory, you see an exponential increase in risk. So women with a BMI above 35 are looking at 50 to 60 times the relative risk of a disease like diabetes. We could show similar curves for cardiovascular disease.
So, John, this is going to sound like a sort of silly question, but I've discovered in working with many of our residents that they actually really don't understand how to measure waist circumference properly.
Yeah.
And I wondered if you can go through that with the audience. Remember, when you and I were in training, we were told not to lay our hands on patients, so that was a boundary violation.
Nobody was telling me how to do waist circumference. The National Heart, Lung, Blood Institute has some guidelines on this, which we can quickly review. Basically, you put the tape measure perpendicular at the level of the iliac crest. So some people, this is the same as the umbilicus, and so people tend to think that's where you put the tape measure, but it's really right at the level of the iliac crest. And you try to have the tape snug, but not too tense and not too loose. And of course, here's the source of variability in waist circumference. And this is why some of the biometric tape measures, running about $35 to $40, are very helpful. They keep the same tension from measurement to measurement.
Now, Rob, not only is excess weight linked to morbidity and mortality, but obviously it has an impact on quality of life. Is there evidence to support this notion?
There's a lot of data about that. On the graphic we'll see here, we know that the quality of life is affected. It affects physical and social functioning when you have excess weight. And importantly, not just the weight itself, but energy expenditure, your ability to interact with others, your energy level to be able to socialize and to work is all affected. We know this from studies. We've underemphasized it in prior studies. Just need to focus on it more.
Well, thank you, Rob and John, for really helping to give clinicians useful tools. And I now really want to give the audience a chance to ask us questions. You can do so by calling, faxing, or emailing us with comments or questions by dialing 800-879-2166, or you can fax your questions to 240-465-5524, or you can email us at questions@cmeoutfitters.com. We look forward to hearing from you. While we wait for some questions to come in, I'd like to see if we've been successful in improving clinician performance in addressing this serious health issue. Let me ask our viewers on the web to rate which of the following is not a criterion of metabolic syndrome. A, BMI over 30, B, waist circumference over 40 inches in men and over 35 in women, triglycerides greater than 150 milligrams per deciliter, Or D, fasting blood glucose greater than 100 milligrams per deciliter. Internet viewers, you'll see a window pop up. Please select your answer and then click on the Submit button. Here's your last polling question. How frequently do you plan to measure BMI for patients who take atypical antipsychotics? Every visit is A. B, quarterly. C, once per year. D, never. Internet viewers, select your answer now. I'm going to go ahead and begin with the questions that have been handed to me that we've received over the web, and then I'm going to ask Rob and John to take a stab at it. First question is, do you ever see movement disorders, and I assume they're referring to extrapyramidal side effects or tardive dyskinesia with high doses of aripiprazole?
We've certainly seen things that look like akathisia with treatment with aripiprazole. I haven't myself seen movement disorders that look like dyskinesias, although I do think that sometimes you'll see people have withdrawal dyskinesias occur when you're switching to an agent like aripiprazole from another drug that may have been causing the underlying movement disorder problem.
We have a number of callers on the line, and the first caller is Dr. Firestone. Dr. Firestone, go ahead.
I'd like to ask a question. If a patient is on an antipsychotic and has dyslipidemia, if you stop the antipsychotic and the dyslipidemia does not change, does that mean that it's not due to the antipsychotic, or is there some other reason for that?
Yeah, so it's a good question, and in the clinical trial data that's available so far, when you remove what appears to be the offending agent, you can see a rapid drop in both total cholesterol, LDL, and triglyceride. I mean, substantial 40 milligram per deciliter kinds of drops. So if you see no change after removing what was the putative offending agent, I would say that's a pretty good de-challenge kind of test. And now you start looking for other sources of risk.
Right.
Here's a question based on the quetiapine data. This is from Woodhaven, Michigan. Should I be concerned with quetiapine 8-week data showing a 37.4 unit increase in triglycerides at 300 milligrams a day, whereas the 600 milligram a day dose patients only had an elevation of 4.7 units?
Yeah, the quetiapine data in terms of dose response for weight, there's a paper that's about to come out. There's an inflection point at about 125 milligrams per day. Less than that, you see about half the weight gain on average that you see above that. There's no dose response data that I'm aware of for effects on lipids. There's a study that's just posted and the paper's being submitted showing that the dyslipidemia with quetiapine may not be about insulin resistance, but about some other mechanism. But in any case, again, no dose response data that's available. Doesn't mean that it couldn't be happening within an individual patient.
Let's go ahead and take another internet question here. This is from Carolyn Masters. Dr. Masters asks a question that essentially relates to two issues. One has to do with the dose-response relationship between antipsychotics and weight gain. You've already mentioned quetiapine.
Yep.
You might want to expand that, one of you. And then the other question relates to whether ziprasidone really needs to be taken with food, and if so, does that affect weight gain or efficacy in any way? Who's going to take which question?
I could do the dose response
Sure, go ahead.
question. So the story with olanzapine, where there's also good dose response data there for weight gain, 2.5 milligrams per day and below, you see very modest weight gain with olanzapine. It's in the 2.5, it's in the 5 milligrams per day and up, where you see largely similar weight gain without statistically significant dose response. So for the other drugs, there really isn't a good dose response story.
That's right, and for ziprasidone, I think our evidence is that although what you eat does affect absorption, and that in some degree fat does help absorb, the amount that you need to eat in a meal to get ziprasidone absorbed well is very tiny. And with good dietary advice, it really shouldn't affect your weight at all to be able to, in essence, eat enough to get good drug absorption.
Well, that's important. Let me say that we have hundreds of callers out there right now who have asked questions, and unfortunately we're running out of time. we're not going to be able to take any other questions. So let's go ahead. Rob and John, I guess we've been pretty good at improving performance. Let's look at the results of the latest poll. So it's very clear now that I'm getting these results being transmitted to me, there was a marked increase in the number of clinicians who will be screening on a very regular basis, and they feel much better about the tools that you've provided with them today. I'd like to close today with a trademark of Neuroscience CME TV. That is, what are the key points connecting the data to clinical practice? Rob, what key points would you like to make?
Well, first, there really is a very high prevalence of risk factors, and they're modifiable in people with severe illness. Next, the agents we use, psychotropic agents, can be a problem. They can negatively affect these risk factors.
John, what key points do you want to leave with our clinicians today?
I'd add two things. One is that mental health practitioners can play a key role in the screening, the front line, primary and secondary prevention screening. And number two, the U.S. Public Health Service message that's especially relevant to psychiatry, body mass index and waist circumference are important tools to identify and address cardiometabolic risk.
Well, John and Rob, thank you again for joining us today.